So we're going to talk about adrenergic blocking drugs. Just as an overview, what the adrenergic receptors do. Okay, your alpha-1 causes the vasoconstriction, pupil dilation, CNS stimulation, bladder and urethra constriction. Alpha-2 adrenergic receptors actually inhibit the effects of the sympathetic nervous system when they're stimulated. The beta-1 adrenergic receptors, that's the heart. So it causes increased contractility, increased heart rate, increased renin secretion, which increases your blood pressure. You have beta-2 adrenergic receptors, which are in the lungs, and they cause stimulation causes bronchodilation and glucogenolysis. Which is when the liver breaks down the stored glycogen into glucose. So it's the release of glucose by the liver. So the first one we're going to talk about is the alpha blockers. They end in osin. There's a few listed there so you can see what they are. So they block the norepi receptor. Their effects, they cause vasodilation, which is going to decrease blood pressure. They cause meiosis, which is constriction of the pupils. They cause decreased tone of the bladder and urethra, which makes it easier to urinate when you have BPH. BPH is benign prostatic hypoplasia, and that's when the prostate squeezes the urethra and makes it hard for urine to pass through the urethra. So if you can dilate that, it makes it easier for males to urinate if they have hyperplasia of their prostate, which you will learn about more in level 3. Indications for alpha blockers are hypertension, so high blood pressure, benign prostatic hyperplasia, BPH, which we just talked about a little bit, and just to counteract injected epi or norepi. So what are contraindications? If they have peripheral vascular disease, we're not going to use it. If they have any renal or hepatic diseases, we don't really want to use it. If they have peptic ulcer issues, we don't want to use it because it actually can cause ulcers or make ulcers worse. And also if they have sepsis. Adverse effects of the alpha blockers are first dose phenomena. Now this is when they first take it, they can have a sudden severe drop in their blood pressure. So ideally when they take it, they should be sitting down or even laying down shortly after. So in case they have that happen, they're not going to fall and potentially hurt themselves. Other adverse effects is orthostatic hypotension, dizziness, headache, and constipation. Interactions are just other highly protein-bound drugs. They're going to compete for the protein. So beta blockers. Beta blockers end in LOL. They compete with epi and norepi. Remember, your beta-1 is your heart, your beta-2 is lungs. They can be selective or non-selective, meaning they can be just reacting on the heart, or they can be non-selective and work on both of them, have side effects for both of them. There are 2 beta blockers that also have alpha receptor blocking activity at really high doses, and those are carvedilol and labetalol. So they have alpha and beta blocking activity, which is different. And whenever medications are different from the rest of them, the others in their class, is something to note. So beta-1 blockers, we talked about, it's the heart. So they reduce myocardial stimulation. So they reduce the heart stimulation. They do this by decreasing or slowing the conduction of electricity that goes through the heart, the electrical conduction through the heart. So this results in a decrease in the heart rate. Because it slows conduction through the AV node, It prolongs SA node recovery also, which causes a decrease in heart rate. You have decreases in myocardial contractility. So the actual contraction of the heart isn't as strong as it could be. And the reason you may sometimes want this is because if you have a situation where the heart is using too much oxygen, and like angina is one of the instances, and we're going to talk about that in a few weeks. But when you have angina, you have a decreased oxygenation. So if we ever want to increase the oxygenation of the heart, then we can decrease the energy that the heart uses. Thus, it increases oxygen to the heart. Hopefully that makes sense. So we're decreasing myocardial oxygen demand by decreasing the myocardial contractility. We're making the heart not work so hard, so it doesn't use so much oxygen. Now your beta 2 blockers are your lungs. They cause bronchoconstriction, which means it's going to narrow the airway in the bronchioles. Okay. Vasoconstriction, this increases peripheral vascular resistance, so it can cause some issues with that. Inhibits production of glucose from the liver in response to hypoglycemia, okay? So this is really important because the liver, and we'll talk about this when we talk about the diabetes medications, the liver really controls glucose along with the pancreas by it stores extra glucose that we have, and when it notices that we're hypoglycemic, when our glucose level is low, it will turn that stored glycogen into glucose and release it into the blood to get our blood glucose back up to where it needs to be. Okay? Well, that's how the liver normally works. Well, the beta 2 blockers can actually decrease the response of the liver to hypoglycemic episodes. So it can actually cause hypoglycemia because it's not responding as readily to low glucose, blood glucose levels, okay? Another interesting thing about that, though, is that beta blockers can also cause hyperglycemia. Because they block beta cells, they can block the beta cells in the pancreas, which are responsible for insulin secretion. So, if they're blocking insulin secretion from the beta cells in the pancreas, then you're going to have higher glucose levels because you don't have insulin, right? So, your beta blockers can actually cause hypoglycemia by the liver not responding, or it can cause hyperglycemia by inhibiting the response of the beta cells in the pancreas. So your beta blockers, we talked about non-selective versus selective. So non-selective means that it is not specific to the heart. Okay, so it's going to have your heart effects and it's going to have some lung effects. Okay, so they can cause either hypo or hyperglycemia, like we talked about. It can cause an increase in triglycerides, a decrease in HDL, which is the good cholesterol. Indications, we use these for heart attacks, myocardial infarctions, cardiac dysrhythmias, because it controls the heartbeat, right, the electrical conduction. With hypertension, with heart failure, when the heart doesn't pump as well as it should, and angina. And we talked about with angina, you have a decrease in oxygenation to the heart. So if we can decrease the myocardial use of oxygen, we can increase the amount of oxygen that actually stays in the heart. So we decrease the myocardial oxygen demand, okay, by decreasing the myocardial contraction strength, okay? So contraindications, heart block, bradycardia, of course. Well, heart block because it already slows electrical conduction, and when you have a heart block, that means the conduction stops at a certain point and skips. Okay, so if you already have issues with electrical conduction, you don't want to add slowness to it. Bradycardia, if you already have decreased heart rate, you don't want to decrease it even further, right? Uncompensated heart failure would just not respond to beta blockers. Pregnancy, and then severe pulmonary disease, because we talked about they cause bronchoconstriction, so that would further complicate things if you had severe pulmonary disease. So they do have a black box warning against abrupt stopping of the drug. If you stop the drug abruptly, then it could exacerbate your angina or even lead to a heart attack or myocardial infarction. So it should really be tapered off slowly over 1 to 2 weeks to be the safest. Okay, so adverse effects. You have bradycardia, which we talked about already, depression, you have impotence, constipation, just slows down everything, fatigue, because of bradycardia can really cause you to be really tired, and hypotension, delayed recovery from hypoglycemia. We talked about why that was, because it inhibits the release of glucose from the liver. Toxicity, if you have toxicity, it's going to be, you just treat it with symptomatic and supportive measures. Hemodialysis may help eliminate the beta blockers from the blood. And then interactions, just it has an additive effect with any other medications with the same mechanism of action. Now, just a list of some beta blockers that we have. The cardioselective, so these are beta-1 blockers, so it affects only the heart because they're selective. You have metoprolol, which is one of the most common beta blockers that we use. It increases survival after a myocardial infarction. It is a high alert drug when it is given IV. They have to be on a monitor if they're on that medication IV. You have other ones listed there, the non-selective beta-1 and beta-2 blockers. So these are just examples of ones that are non-selective. So they're going to have heart effects, but they're also going to have some lung effects as well. And then your alpha and beta blockers, they're beta blockers and they're also alpha blockers, which is really interesting. In fact, carvedilol is also, let's see if we can write on here. Hold on, let's make this big so I can write. Let me erase this dot here. Maybe. Okay, we'll just keep the dot. So it's also, oh, I forgot I was in red. Well, you know what, you might want a good color. Let's do purple. So carvedilol is not only an alpha and a beta blocker, but it's also a calcium channel blocker. And we're going to talk about those later in the semester. So how crazy is that? So you have, blocker would be good, right? Block. Goodness gracious. Well, okay. So carvedilol is an alpha blocker, a beta blocker, and a calcium channel blocker. So it's really good with slowing the progression of heart failure. So when you see a patient on one of these, you'll be like, whoa, okay. We're trying to do a lot of stuff. This is like a 3-in-1 medication here. Okay. Labetalol is really good with severe hypertension. In fact, it's used for hypertensive emergencies. Now, when we're assessing a patient that is on a beta blocker, we're going to look at their past medical history. Oops, didn't mean to write that. We're going to look at their past medical history, their review of systems, do they have anything going on, okay? Their respiratory and cardiac history, right? Because a lot of the beta blockers are non-selective, so they're going to affect respiratory stuff as well. So we need to know, do they have COPD? Do they have asthma? Do they have hyper or hypotension? What kind of cardiac disease? Do they have heart failure? Any heart issues whatsoever, okay? We need to know about these. The nursing actions, we need to know their I's and O's and daily weights, because we need to know if they're getting edematous. When you have high blood pressure, you start to have edema, and the best way to notice edema is to do daily weights, because a lot of times patients are fluffy and you might not notice a little bit of extra fluff, right? Which is actually edema, unless you're weighing yourself every day. And so that's a way for them to be like, okay, keep an eye on that edema, keep an eye on my blood pressure. Breath sounds, because if they're on a non-selective, we're going to be listening for any bronchoconstriction noises, which would be wheezing, okay? Or if they have edema, we can hear edema by crackles in the lungs. So you can assess for edema by listening to the lungs, listening for crackles, and by having them do those daily weights, okay? And we're going to check blood glucose levels, right? Because we just saw they're at risk for hypoglycemia and they're at risk for hyperglycemia, okay? Of course, they're at bigger risk if they have diabetes already, but even if they don't, they're still at risk. So, they need to be aware of that. Implementation. So basically what we want to do is we want to minimize adverse effects, okay, of the medications. So they're going to have, more than likely, orthostatic hypotension, so they need to change positions slowly. They need to avoid anything that leads to any further vasodilation. So that would be like heat, like a hot tub or really hot bath, or hot environments, alcohol. Because they're going to more than likely have constipation, they need to increase their fluids, maybe take fiber supplements, okay? When we're assessing, we need to make sure we're counting an apical pulse for 1 full minute, okay? Make sure you guys remember how to count an apical pulse. It's at the 5th intercostal space at the left midclavicular space, okay? You want to document the blood pressure standing and laying down, because that would indicate whether they had orthostatic hypotension. You may need to report any systolic blood pressure that's less than 100 or a heart rate that's less than 60. Usually in those cases, we're going to hold the medication. With daily weights, you want to report any weight gain of 2 pounds or more in 24 hours. Or 5 pounds or more in 1 week, okay? Because again, an increase in weight is probably an increase in edema, which means there's an increase in blood pressure, okay? Or their heart not functioning correctly. Also remind them to report any muscle weakness, any shortness of breath, and any edema that they notice, okay? And also remind them they must be slowly weaned off these drugs so we don't cause problems, okay? Remember, they can cause an increase in angina or even a myocardial infarction if it's an abrupt stop. So they need to wean it slowly over about 1 to 2 weeks. So when we're looking at patient-centered teaching, we want to give them written and verbal information. And the written information is so that they have something to reference later on. It can be overwhelming when you're getting all this information, and having something written that they can refer to is a great thing so that they can remember or look to it to remember what you said. A medical alert bracelet. They need to take their medications exactly as prescribed. If they skip or accidentally omit a dose, they need to contact their prescriber, okay, to find out what to do next. CNS stimulant should be avoided with beta blockers because they can, you don't want to cause any irritability of your cardiac or your central nervous system. So they should be avoided. They need to avoid alcohol or anything that causes vasodilation, so like the hot environments, right? Warn them that constipation may develop, and so they need to drink lots of fluids and maybe take a fiber supplement. They need to report any palpitations, any chest pain, any confusion, weight gain, dyspnea, both of which would tell us that there's edema going on, or nausea or vomiting. So your key points. Alpha blockers cause vasodilation. Your beta-1 blockers decrease your heart rate, decrease contractility, and decrease conduction of the heart. Your beta-2 blockers cause bronchoconstriction. You're educating patients. Remember, they need to do daily weights. It's the best indicator of edema. Avoid sudden position changes because of that orthostatic hypotension. They need to increase fluids and fiber intake because of that constipation. And report immediately any weight gain, dizziness, fainting, heart rate below 60, or a systolic blood pressure below 100.